At this point, we're going to bring Dr. Anthony back up, and you don't need an introduction on him because he got a great introduction this morning. He's going to talk a little bit about the importance of keeping that serotonin under control.
Okay, so what I want to tell you in 20 minutes is right here. So I could just spend 20 minutes and never advance the slides. What I want you to understand when we talk about serotonin in the context of neuroendocrine tumors, we're looking at it as an amino acid that is overproduced. It's the driver. Control the serotonin, control a lot of the complications, some of the comorbidities. We know it plays a central role in the development of carcinoid heart disease. It may not be the causative factor, but we know it gives us an insight to those people who are at risk. And that the fibrosis going on above the diaphragm in the heart is also going on below the diaphragm, but the pathophysiology of that is right now is being studied in depth. I know at least one pharma company that's interested. The early data is it's different than the fibrosis occurring in the heart. And we also have to put carcinoid syndrome complications in the context also of what's happening in the lungs. And we see pulmonary hypertension and pulmonary artery hyperplasia going on there. The third point is there's data, and I'll show you that in the laboratory models, that shows that serotonin can stimulate cells to grow, tumor cells to grow. So it can become related to some of the issues Dr. Liu talked a little bit about this morning, Dr. Das, in terms of how the pathophysiology is playing out. These cells are sensitive to growth factors, some of which they produce themselves. Controlling serotonin exposure is important to improve the quality of life and for the prognosis of people with carcinoid syndrome. However we can do that. We can argue PRT, Telotristat, somatostatin, surgery, local regional therapy. We can talk about it, but we just have to get it done. What is serotonin? Nothing you ate today had serotonin in it. You don't go to the store and buy serotonin. You can buy the capsules on Amazon, okay? But I doubt too many people here buy serotonin capsules. You get it from tryptophan. Tryptophan gets a bad rep in the world of foods. Eat turkey, you go to sleep. The more you eat of almost anything, doesn't matter if it's turkey or not, you go to sleep, right? So it's really not the turkey. But tryptophan just is that soporific, you think about it as being sleep. It gets converted to serotonin. So the abbreviation here I'm going to use is 5-hydroxytryptamine for serotonin. So it goes from tryptophan to 5-HT in 2 easy steps. Where is the serotonin made? The gut. That's where 90% of it comes from, the gut. We know that it's stored in the platelets. It's not made in the platelets, but it's stored in the platelets. And we know that the CNS has its own factory of serotonin production. So it's going to make serotonin. And then the tumors are going to make serotonin, right? Because these tumors are derived from the cells in the gut that are spread to elsewhere. So with that background, we can understand that serotonin is central to this, but does it cause people to feel better? If you have your own serotonin producing factory in your body, are you happier? The answer is no, because it doesn't cross the blood-brain barrier. But it is associated, the CNS is associated with that feel-good hormone, the CNS serotonin. That's where all the confusion with SSRIs come in, because we associate serotonin with the feel-good hormone, and then we look at it from what's happening in the gut. It's not the feel-good hormone, It's not the production, that's not the feel-good hormone where we're attributing it to. So we get confused by saying, oh my God, we have people who have too much serotonin levels in their blood, but they're depressed. Well, it's simply, and then we can't use the SSRIs because it would conflict with the serotonin. So this is where all the confusion. Big Pharma will never study this. Never study the serotonin compartment of the peripheral nervous system, central nervous system. There's nothing in it for them. Absolutely nothing in it for them. We know where the serotonin's stored, in the granules of the cells that make it. And we know that the neurons have their own machinery. The really strange thing about it is that the serotonin that's made in the periphery doesn't cross over into the central nervous system. Isn't that really interesting? So if serotonin is going to get inside the brain, it's got to be made by tryptophan the same way the enterocyte, the enterochromaffin cell makes it. And the beauty there is it's a different isoform of the enzyme tryptophan hydroxylase, so that when we block serotonin formation in the periphery, guess what? We don't block it in the brain. Isn't that cool? That's pretty cool. That's pretty cool. So that when this drug, Telotristat, was being developed, that was the number one concern with the FDA. You're going to cause depression. You're going to cause mental illness. The Serotonin Discovery is really a wonderful story in medicine. It dates back to 1935 when this Italian scientist, Erspamer, identified a substance being produced from the EC cell. And to kind of think about 1935, how did they get the EC cells away from all the other intestinal cells? And then how did they go about studying it in terms of isolating this compound that he called enteramine? Because it contracted the gut. So that was the very first indication in the medical literature that it was there. And then, about 13 years later, a group at Cleveland Clinic also observed that there was a vasoconstrictor substance in serotonin. So now we have the Italian investigator seeing, something's in the gut, and now we see something in the platelets. And then they figured out that it was the same thing. So it took them 4 more years after the discovery that it was exactly what Erspamer had identified, and the word serotonin then came into our common jargon. And then, about 2 years later, it was connected to Carcinoid syndrome, 1954. And that happened in Sweden and Stockholm, and Page and others in the U.S. So it was a dual contribution between cardiology groups and a group in Stockholm. So we know that serotonin is involved in normal physiologic behavior. It's a biogenic amine. It has a lot of diverse functions inside, outside the CNS. When we talk about its diverse functions, these are, I don't want to say this is totally comprehensive, but look at all the things it does. It regulates heart rate. It induces atrial fibrillation in high serotonin states. It's involved in heart development in the embryo. It's involved in valvulopathies. It's involved in the remodeling in congestive heart failure. Regulates respiratory drive. May be involved in sudden infant death syndrome. Involved in the pathogenesis of pulmonary hypertension. Regulates gastric emptying, intestinal peristalsis, intestinal secretion, colonic tone, pancreatic secretion, beta cell regulation possibly, nausea and emesis. We have the whole HT3 class of drugs to regulate that. Involved in irritable bowel syndrome. Platelet-derived serotonin involved in the hepatic regeneration. When you go in and cut out part of the liver, it regenerates. Part of that regeneration is driven by serotonin and platelets. Pain and nociception. Complex effects on the HPA axis and stress regulation responses. And then early embryonic responses. These are all really just minimizes, you might say, or describes all the many things it can do, because this system consists of 18 genes, including the serotonin receptors, one transporter, several of which has multiple isoforms, which creates about 18 proteins that 10 proteins that these 18 genes are responsible for. So this receptor signaling transduction system that regulates it involves simply a large number of genes. So it's rather complex. So this is the diagram I want you to recall. This is the gut villi, and we can see that the Enterochromaffin cell that makes the serotonin is throughout the GI tract, but it's concentrated in the terminal ileum and some in the proximal colon. So that this is why we see this region of the intestinal tract more commonly involved, because of its concentration of these cells. And so these cells make it, and look, the serotonin then is released and then goes into the blood from these EC cells. So that's where that's where it comes from, is the gut. It's also produced in the mesenteric plexus in the gut, and it acts as a neurotransmitter. So it gets into the blood, and then it works locally to propel motility. So we know these cells there are certain things that can influence them. We know they reside along with the epithelial lining. So if we denude the epithelium with toxic drugs and radiation and stuff, we can certainly alter gut physiology. We know that the enterochromaffin cells are the most common type of neuroendocrine cell in the GI tract. And we know that this modulates the neuron signaling in this enteric nervous system, which comprises a subgroup of the peripheral nervous system. And that the serotonin acts within this enteric system in synergy with other digestive hormones. It does not act by itself to regulate the sensory and motor GI effects. Carcinoid syndrome was touched on this morning by Dr. Das. We know it's a tumoral release of serotonin that causes a whole host of symptoms. We know that we can improve the symptoms with the suppression of release with somatostatin analogs. And the next story after 1954 would be about the mid-1960s, when the inhibition of serotonin synthesis by parachlorophenylalanine was proposed by the group at NIH. So that was tested up until the early 80s. Parachlorophenylalanine crosses blood-brain barrier. There was too many CNS side effects. It worked. It did exactly what it's supposed to, but people couldn't tolerate it. But as you read through it, you'd be amazed that some people could tolerate it and they really benefited from it. But that drug could never get traction. So if we talk about serotonin and NETs, we're seeing a cell that here is secreting serotonin. The serotonin itself feeds back on serotonin receptors on itself. When it does this for the HT2 cells, there's a stimulation of certain myelogenic pathways that stimulates growth, and then when it hits the HT3, 1A and 1B receptor, it blocks cyclic AMP, which then releases the inhibition to make cells grow. So this is the pathway that we feel like, or we think, that's being postulated, that is contributing to cell stimulation. So what happens in cells as it relates to the immune system? When tryptophan gets depleted, and in pregnancy there is tryptophan depletion. In cancer there can be depletion, inflammation, and an autoimmunity. When tryptophan is depleted, it has an effect on suppressing the immune system. So this is an area that's being looked at in great detail right now in a number of different centers. This morning we talked about the syndrome. We talked about the severity of diarrhea and flushing being the number one, but fatigue is right there. I have found that if we inhibit the flushing and the diarrhea, the fatigue goes away. In most people. So we talked about how tryptophan goes to serotonin. What happens after that? Well, this tryptophan hydroxylase is the rate-limiting enzyme that takes tryptophan to serotonin. After it's made, it's stored. It mostly, since the disease in the liver, it's being stored there. The metabolite of 5-hydroxy-indolacetic acid is the gold standard to measure changes over time, and that's where the blood serotonin gets converted and filtered by the kidney. It gets converted in the blood by monoamine oxidase, aldehyde dehydrogenase, 2 different steps, and then it ends up being filtered in the blood. And we know that urinary 5-HIA serves as an accurate, sensitive biomarker for serotonin management. So what happens in the tumor is dysregulation of the catabolism of serotonin. So under normal circumstances, about 99% of dietary tryptophan is metabolized oxidatively into nicotinic acid and is converted to 5-hydroxytryptophan. In carcinoid tumors, there's a disequilibrium where it says there's more of a 5-hydroxylation of most of the tryptophan that goes into the production of 5-hydroxytryptophan to serotonin and then to 5-HIA. So that patients with a syndrome are because of the conversion of tryptophan to serotonin can be at increased risk for this dysregulation and potentially a depletion of tryptophan and the complications that go on with that, with skin disorders, etc. So when we move into the heart and fibrosis, this is simply an example of showing that the heart itself, this is a 2D echo that we can see a sagittal view, and here's the 4-chamber view. We're looking right down into the right ventricle, and this is the pulmonary, this is tricuspid valve, and this is the pulmonary artery up here in the right atrium. So you can see that this RV and this area here, usually you don't see the pulmonic valves out well. And in this case, they're thickened and there is a certain degree of insufficiency. So this is what we're really looking at, is does the heart, is the right heart valve affected? That's the hallmark of carcinoid heart disease. We know it correlates, outcomes correlate with the development of carcinoid heart disease because we know the prognosis is related to what the levels are. And I won't go into too much detail here, but the survival, when the 5-HIA levels are low, people do better. Again, these are old data that now, when we've got better ways of controlling it, we certainly, I think, in my personal experience, have better outcomes than what these data had before. So the risk of progression is also related to the 5-HIA exposure, and these are 23 patients. 8 of them had developed carcinoid heart disease, and there's a correlation here with the increase in serotonin as measured by 5-HIA. So a lot of this work has been done at Mayo and Rochester. They assembled a group early on. They have the largest database, and many people go there for complicated carcinoid heart surgery. When we look at the progression of it, it's associated, and this is not where we can actually prove that it's linked as the causative factor. I think there's probably other transforming growth factor beta and some other, maybe FGF, that also contributes to this. But the bottom line is people who have progressive disease will have a tendency to have higher levels than those who do not have progressive disease. The mesenteric fibrosis, again, links to serotonin overproduction. We think that it develops from either local or distant effects from the primary tumor, and typically when we see these primary tumors, we may see actually more fibrosis there than we actually see live tumor. And that was a little startling at first when people realized that. When we see CT scan evidence and we go in and look at the surgical specimen, is a disproportionate of what we see as scarring, and there may be more scarring than there actually is tumor. Pulmonary artery hyperplasia and hypertension is also part of the clinical manifestation of serotonin overproduction, so if we can keep that low, then we can improve the outcomes there as well. So to not spend too much time on the unmet needs with carcinal heart disease, this is an area that there's a lot of interest. It's not as common as it used to be, thank God, but the current ways that we're managing it with diuretics, loop diuretics, somatostatin analogs, and medicine, balloon valvoplasty, surgical valve replacements, all of these have their limitations, and we would prefer never to have to send these patients to cardiology, to cardiac surgeons, or to deal with it at first. So to quickly talk about how it's used as a stimulant, of a growth stimulant, we can look and correlate outcomes with levels, and people who have had levels less than 20 for 5-HIA or greater than 20 follow a different survival curve that is more detrimental. You can say 33 versus 90 months in this relatively small group of patients, but at least it gives some idea that supports the fact that controlling serotonin is really central to what we're trying to do. Serotonin is a growth factor in these preclinical models. This is a stimulation of an acetyl phosphate, which is a molecule that's involved with G protein coupled receptors and growth monogenic pathways. We can see that these signaling pathways, ERK activation, IGF-1 secretion, where we look at control substances and then look at different concentrations of serotonin, that we can stimulate these specific pathways to turn on cells to grow. When we translate that into 3 different in vivo models, or in vitro models, preclinical models, these are 3 different cell lines that make serotonin, and when there's an inhibitor for serotonin present, then the cells will die. This is the control for these 3 cell lines up here, and this is a MTT assay. That's a fluorescent assay that it's a dye that doesn't take up, then the cells are dead. And in this assay with serotonin, we can see that there's, in each one of these models, that there's a when you inhibit serotonin, we encourage the cells to die. So this brings us up to where we are with Telotristat. If we can identify a target, then we should be smart enough to go after it. The parachlorophenylalanine in the 60s was that target. It's too toxic. Now with Telotristat, we're able to go through, block the first step of serotonin synthesis, and then have less production in the cell, and supplement that with the suppression with the somatostatin analogs. So this is kind of where I entered medicine in the 1980s. Dr. Cole's group published in the New England Journal in a fairly small group of patients, but he saw that where more than 50% reduction in 5-HIA occurred in about 70% of these subjects. So this is so great, there was no prospective randomized trial ever needed. And from that, the next step was tryptophan hydroxylase identification, and then looking at where that is on the genome in the genes that code it, and then to figure out inhibitors. And it was really the science at Lexicon that worked backwards to say this is the receptor, this is the enzyme, this is what we want to inhibit, and that was created to do exactly what they intended to do. So what we give now as Telotristat ethyl is actually a prodrug that this water and an esterase in the blood activates it to the parent drug that does the inhibition. And then 2 years ago, the registration trial was published in the Journal of Clinical Oncology that basically showed that Telotristat ethyl is effective in treating carcinoid syndrome in patients who are inadequately controlled with the somatostatin analog. So this was a breakthrough experience for us. It gives us another opportunity not only to control symptoms, but really to lower the 5-HIA and have an impact on potentially carcinal heart disease. So these are the data that the FDA ruled on. This is the mean change from the baseline in bowel movements. So these patients would go through 30 days of a diary, they go through 90 days of a blinded study, and then they go through an open label period of another 18 or so months. And this is basically how the data showed enough to get it approved. When we look at the 5-HI, there was a dose relationship. The 500 milligram 3 times a day dose had a greater effect, but it wasn't deemed enough from the 5A from the way Lexicon approved it, not for 5-HI lowering, but for diarrhea control, that we were not able to get the 500 milligram dose. In some of my patients, I've been able to do it when I really want to better control 5-HIA. So going back, we know that serotonin is overproduced and is the driver of carcinoid syndrome. We know it plays a central role in the heart disease, in the fibrosis, in the pulmonary artery pathophysiology, and we know that it has mitogenic or stimulatory, cell growth stimulatory effects on the tumor, and that exposure is what we really want to limit in our patient population, however way we can do it. So I went over a few minutes, but hopefully it's worth it.